Welcome everyone, let's jump right in. Today, we're building the ultimate high-yield study guide to help you absolutely crush your upcoming medical board exams. We're going to master osteomyelitis and prosthetic joint infections. We've pulled together all the textbook pearls, the key clinical guidelines, and the absolute must-know pathogenesis data into one rapid-fire explainer. So if you want to walk into test day totally confident on bone and joint infections, you're in exactly the right place.
Here's our game plan for today. We'll start with mechanisms and basics, then move into vertebral osteomyelitis, followed by prosthetic joint infections, diabetic foot, and we'll wrap it all up with a lightning round of exam pearls.
All right, Section 1, Mechanisms and Basics.
Before you even think about memorizing treatments, you've really got to understand how these bacteria actually get to the bone in the first place. There are basically three classic pathways that show up on literally every major exam. First up is hematogenous seeding, which just means it travels through the blood. Think of kids getting long bone infections or adults getting vertebral infections. Second is contiguous spread. This is a direct hit from the outside, like from orthopedic surgery or an open fracture. And third, we have vascular insufficiency paired with neuropathy, which is the classic setup for diabetic foot osteomyelitis. Nailing down which pathway you're looking at instantly narrows down your differential.
Now, here is a massive trap that catches so many test takers. When a question asks you to distinguish between acute and chronic osteomyelitis, your instinct is probably to look at how long the symptoms have been going on, right? Actually, scratch that. Do not do that. The crucial exam distinction is entirely about whether or not bone necrosis, also known as a sequestrum, is present. If it's acute and there's no dead bone, antibiotics alone will usually do the trick. But if it's chronic and you've got a necrotic sequestrum, you absolutely have to combine antibiotics with surgical debridement. That dead bone literally has to come out.
Let's roll into Section 2, Vertebral osteomyelitis.
This is the most common form of hematogenous infection in adults, and the numbers tell a very clear story about where these infections like to set up shop. The lumbar spine is the overwhelming favorite here, claiming 60% of pyogenic vertebral osteomyelitis cases. The thoracic spine takes about 30%, and the cervical spine gets just 10%. And the bug? Well, Staph aureus is the heavy hitter, causing roughly half of all these cases. Okay, if you suspect vertebral osteomyelitis, you cannot mess around with the workup. MRI is the absolute gold standard here. It's the most sensitive and specific imaging test we have. And here is a fantastic clinical pearl for you. C-reactive protein, or CRP, is elevated in 100% of these cases in the literature. 100%. So if your patient has a totally normal CRP, you really need to second-guess that diagnosis.
Treatment duration used to be a long, grueling 12 weeks of IV antibiotics. That was the dogma. But modern evidence-based medicine completely flipped the script. You need to know that a major randomized trial proved a 6-week course is strictly non-inferior to 12 weeks. Prolonged treatment is pretty much only for complicated cases now, like if there's an undrained abscess or spinal implants.
Moving right along to Section 3, Prosthetic joint infections.
Joint replacements are everywhere now, which means examiners absolutely love testing this. The secret to cracking prosthetic joint infections is all about the timeline. The timing literally tells you the bug. Early infections, less than a month post-op, are dramatic and fiery, usually driven by Staph aureus or gram-negatives. Delayed infections, anywhere from 1 to 24 months, are much more subtle. But check out the late infections, over 2 years out. These are your low-virulence bugs like coagulase-negative staph, slowly eroding the bone. Just don't mix that up with acute hematogenous, where a patient is years out, doing great, and then suddenly gets a massive Staph aureus blood infection that seeds the joint in a matter of days.
When a joint is infected, the biggest question is, does the hardware have to come out? Surgeons obviously want to retain the implant, but you can only attempt that if 4 strict non-negotiable criteria are met. To remember these, use the acronym ASSS. You need an acute infection, a stable implant, it must be susceptible to a biofilm-active antibiotic, and the soft tissue has to be in good shape. If literally even one of those is missing, the implant usually has to go.
Speaking of that third criterion, biofilms, there's a hard and fast exam rule for staph embedded in a biofilm on a prosthetic device. Rifampin is your magic bullet here. It's the only antibiotic proven to work against it. But listen to me carefully. You must never, ever give rifampin on its own. If you use it as a monotherapy, resistance happens incredibly fast. You always have to pair it with another active agent, like a fluoroquinolone.
All right, Section 4, Diabetic foot.
Let's talk about the unique, often super frustrating world of diabetic foot osteomyelitis. You don't always need million-dollar imaging to figure this out. The simple probe-to-bone test is insanely high yield. If you have a hospitalized diabetic patient with a chronic, deep foot ulcer, and you can take a sterile metal probe and literally tap the bone at the base of the ulcer, well, the positive predictive value for osteomyelitis is right around 90%. It's just a brilliant, low-tech bedside tool that examiners definitely expect you to know and use.
But here is where people get tripped up. 24%. That is a shockingly low number, right? Well, that's the miserable concordance rate between true bone biopsy cultures and superficial wound swabs. Meaning, if you just swab the top of a nasty diabetic ulcer, you're mostly just growing whatever skin flora happens to be hanging around, not the actual pathogen destroying the bone. This perfectly explains why wound swabs are almost always the wrong answer on your exam. You have to get a true bone biopsy to direct your antibiotics accurately.
Section 5. Exam pearls. Let's do a quick lightning round.
Okay, picture this classic ward scenario. You've got a young male patient presenting with a subacute, dull ache in his tibia or femur. It's been bothering him for about 3 months. The workup finally grows Staph aureus. What is the specific eponym for this diagnosis?
It's a Brody's abscess. This is a classic presentation of subacute osteomyelitis that walls itself off and acts super sneaky, usually in the long bones of young guys. Lock that Staph aureus association into your brain right now because question writers absolutely love it.
Let's rapid fire through a few more high-yield clinical associations. If a vignette mentions sickle cell disease, your brain needs to instantly shout salmonella, even though Staph aureus is still common. IV drug user? Think Pseudomonas aeruginosa and Candida. What if the patient has neutropenia or a GI malignancy, specifically cecal cancer? Clostridium septicum is your go-to board answer there. And finally, Pott's disease is, of course, tuberculous spondylitis, caused by Mycobacterium tuberculosis, and it loves to target the thoracic spine.
Let's try another high-yield one. You diagnose a patient with vertebral osteomyelitis and their blood cultures come back positive for viridans streptococci. Where did it come from? What's the hidden primary source you absolutely have to hunt down in roughly 50% of these cases? The answer is endocarditis. Viridans strep loves setting up shop on heart valves, and that continuous bacteremia directly seeds those highly vascular vertebral endplates. So if you see viridans strep in the spine, you immediately order an echo. No questions asked. We've covered a massive amount of ground in this explainer today, from the mechanisms of necrosis to the hard rules of rifampin. So I'm going to leave you with this challenge. The next time you see a chronic diabetic foot ulcer on the wards, are you going to settle for a lazy superficial wound swab, or are you going to remember that pathetic 24% concordance rate and demand a real bone biopsy? Take these pearls, apply them clinically, and you are absolutely going to dominate your board exams. Thanks for joining the Study Guide Explainer, and keep up the great work.